And I'll just pass the microphone on to William McGuinnes, who's going to tell us about eHealth the Australian way. You want this one?
This will be okay. I think yes, I can see. Sort of see. Have we got the clicker? Yes, thank you. We want to keep this fairly practical, this presentation, so I've invited Donna Angel to speak after me to talk really about how the service she delivers and some of the practicalities she faces. But I begin with just a bit of an overview. Within Australia, the tyranny of distance has driven the need for us to actually explore this technology. And as humans use any technology, they will replicate what they do, then they will innovate, start to look for new ways of using technology, and then they'll transform what they do so what they do can't work without the technology. It's quite well documented in informatics literature. So in Australia, we started using it to talk to patients, okay, in the different sorts of areas. And when we talk to patients, of course, we have the various modes, you know, be it right the way through from emails and that between ourselves or the patients, to things like teleconferences, video consultation, remote investigations. But more importantly, we're now starting to say, why can't we innovate with this material? Why can't we look at using technology to set up a triaging system where we use technology for the patient to help themselves initially, and then if it doesn't help them, or there's another level they can go to, like a call centre or some sort of telecommunication advice, and if that doesn't work, then there's some sort of face-to-face service they need. So you're actually triaging the system from home. So IBM have an R&D centre in Melbourne, Australia, and we've been working with them about smart homes, and there are textile peoples at both the Royal Melbourne Institute of Technology and with IBM that we have carpets now that will measure your blood pressure when you walk around in bare feet. We now have socks that you can put on that will actually measure the pressure your feet are under. So for patients who have neuropathic problems, such as diabetes, it will send a signal to their mobile phone to say your foot's under too much pressure, relieve it. So that's the sort of next level, if you like, of eHealth. So we're giving feedback loops to the patient so they can improve things for themselves. But then should it not help, there's the telecommunication links to the expert, and then if they really need it, they come to the face-to-face interaction for some sort of intervention. And as robotics improve, we will even see that face-to-face start to drop off. So at the moment, the robotic intervention lives pretty much in the military. So they've worked out that a surgeon's too expensive to put in a combat zone. So they put the surgeon 400 kilometres away and then use robotics to operate on the poor injured soldier to do the surgery. That will become much more mainstream. So we'll see the need for face-to-face to decrease as robotics improves as well. So these are some of the smart health, smart home type technology we've talked about. And already you're seeing now there are switches you can buy, you plug in, and your iPhone will let you switch things on and off from the office. You know, your television, your heater, your oven. And they're available now commercially. Yep. Just in case you missed it the first time. The other thing you'll see too here is that you're now seeing the ability to connect a number of things to mainstream technology to do investigations. So otoscopes and ophthalmoscopes now are available for your iPhone. You can actually click them on like this and then get the patient to hold it in their ear, and you can look at their eardrum and see what's happening. Between this person and this person. So even though you've got this happening, there's often the need for somebody to be with the patient to just take a dressing down, for example, or to tell you what it smells like. You know, those sorts of things. So this is becoming a very important component. The other thing we're starting to experiment so they would have the GP there. and the GP would talk to the psychologist until the GP says something to the psychologist the patient disagreed with. Then they say, excuse me, and eventually now you've got the patient talking to the psychologist and the GP. So people get fees for this as they get fee for service for anything else. It's not an add-on service. We have a small document available on our website free of charge that is our first attempt at really trying to put some of this together, and we're happy to be part of the EWMA initiative to develop this further into a more comprehensive document. I'm going to hand over to Donna now to talk about what she does from a pragmatic point of view.
Thanks. Thank you, Bill. Sorry, I have to try and see my slides. So I'm just going to give you an example of the way I run my telehealth service. We know that Australia is a large continent. Most of us live along the coastline. You can see Europe and the UK fit in quite nicely. I live in Western Australia, so that takes up 1/3 of the Australian continent. The population is only 2.5 million compared to Spain, which is 47 million, but most of our specialist services are right down there where that little dot is. Otherwise, everybody's dotted along the coastline or in the centre near the desert. There's vast distances in between. That's just to let you know where I work. Royal Perth Hospital, situated on the river, quite a pretty city. And of course, like Spain, we also have pretty lovely beaches too. So we provide telehealth to 87 different locations. The red ones that are pointed there are major telehealth centres. The ones in blue, that's for our Aboriginal or Indigenous population. So they're really isolated, thousands of kilometres before they get to a major centre. At the organisation we work in, this is just an example of the telehealth services that we provide. So quite a broad range of services. We also provide education, both informally during our telehealth consultation and formally. All of our lecture theatres are equipped with video conferencing equipment. So actually today, as I speak, we're running a wound care study day at Royal Perth Hospital, and that's getting teleconference to all the rural sites. So we do that for most of our education. I been running my clinic since 2006, so quite a while. It's nurse practitioner led. I have a weekly clinic, so I have a designated time when I have the clinic in progress. At the moment, I can only see follow-up patients. I don't have the resources to see new patients, so I'm closely aligned with the Department of Vascular Surgery. So most of the patients that I'm dealing with have had, toes amputated or surgical wound dehiscence, but quite a complex group of patients. I have 2 clerical staff who support my telehealth clinic. So one who works with me, she'll organise the bookings into our booking system. She also notifies the patient. She also makes sure that I have the notes available during my telehealth consultation. At the moment, we don't have electronic records at Royal Perth, or in WA for that matter. There's another clerk, and she liaises with the remote site to make sure that they're aware of the dial-in numbers, for example, and the time that the appointment's there. And we do this in association with our country health service. This is just an example of how we run our service. So my clinic, believe it or not, is in the library. I have a designated room there. You can see at this end would be myself. There'll also be the telehealth coordinator present. She does all the dial-in and moves the camera in and out for me. At the other side, there'll be the nurse plus the patient. Sometimes we have doctors there as well. It just depends. Oops. During the consultation, I like to receive images of their pictures. It's quite hard to just zoom in on the wound, so it's quite good if we receive images. And also some of our telehealth clinics at the rural site, it might be in the tea room, so I certainly don't want them taking dressings down there. And there's actually one, for some reason, it's set up in the storeroom. It's unusual. During the consultation, we'll have access to the patient's results, radiology, blood tests, and of course we run our service through video conferencing. This is just an example of some of the types of wounds that we're dealing with. So the complex patients, probably I'm sure the same in Europe, there's a high push to discharge patients early, so they're getting discharged early with these complex wounds. Most of my patients, fortunately, are Indigenous, but however, with that population, there's a high incidence of end-stage renal failure, the highest in Australia in that group, diabetes mellitus, and of course, So what are the benefits? It allows us to discharge patients early, as I've said. Now, for the Indigenous patients, some of them haven't even seen a major centre, a city. They haven't been on an aeroplane before. They're quite a tight group of patients. They're very family orientated, so it's good for us to get them home early so that they don't feel so socially isolated. It allows us to have overall clinical governance of our patients with complex wounds. So once they're discharged, we still maintain governance of, the care that they're receiving. So if they're being treated for osteomyelitis, then the ID physician may be with me, or the podiatrist. Also, we have a high turnover of staff, so it just allows us to educate them as well at the same time. It helps us to identify if wounds are deteriorating. I mean, you would think that would be, people would, but unfortunately during the telehealth consultation, sometimes we see some quite alarming situations where we need to arrange to get them on an aeroplane and down to Perth soon. Allows us to follow up our patients in a timely manner. Some of the sites there aren't aeroplanes that are going in and out every day, so for them to come back to Perth for follow-up, it takes quite a bit of coordinating. So we're getting to see them in a timely manner. And it gives us the opportunity to upskill our rural healthcare professionals. There's a high turnover of staff here, so that education component is really important. It's certainly proven to be cost effective. If you look at up the top there, Kununurra, that's about a 4-hour flight to Perth, it's about $1,500 return, and that doesn't take into account the loss of time from work if they're working, or their accommodation, and also it's a 3-day round trip for them to come down just for one face-to-face, or longer if there aren't flights every day. So it's certainly proven to be cost effective and saving our patient-assisted travel scheme a lot of money. There are some challenges, of course, human challenges. At the rural site, they don't have designated time to attend the clinic, so often the nurses are pulled from the ward to come and be in attendance, or they may be out in the community and they'll have to come back and be in attendance. The other thing as well is they're not educated, so often during the telehealth we have to educate them on how we run our clinics. Certainly the equipment varies from site to site. In some of the rural sites, it's definitely in need of an upgrade. There's the issue of the security of patient information, which our IT system are working on at the moment, and the medical legal issues are yet untested. This is just an example of my colleague, Beth Sperring. She runs the plastics telehealth clinic. So her clinic is quite different to mine in that they see new patients, they also see follow-up, they run their service every day, that's all she's employed to do is telehealth. They will have a consultant in attendance, occupational therapist as well for the hand patients, so it's just a little bit different to the way my service is run. And I'd like to thank you for your attention.
Thank you very much for this presentation, William and Donna. I was just thinking that you've come quite a way forward in Australia, and maybe we should simply move all of Europe to the Australian continent. You showed that very nicely. There's room for it. During the process in Denmark, we encountered that there would be more telemedical consultations with nurses, and you, Donna, said that you were upskilling the rural health professionals. Does that mean that you have more contacts with these persons, or do they function autonomically, or what would you say? It's just for the logistical part of it, because if we have to put this into the clinical situation, it's important to know whether you have more consultations or contacts.
Thank you. We're not necessarily having more. When I say upskilling, really, sometimes what we're doing is if it's someone with a venous leg ulcer, then we physically show them how to do compression bandaging. or with the high-risk foot, the diabetic foot, then we do spend time educating them on, what things to look for, how to apply the dress, and when to contact us. Does that answer your question?
Okay, yeah. How do the podiatrists come into place here?
The podiatrists come in, but they also have a telehealth service, so they have their own, but if we have mutual patients, they'll join me as well, and they're looking at their foot to make sure that they've got appropriate offload, and although they can't do it, they can, perhaps say, look, you need to come down, or just check to make sure that everything's okay.
Okay. Any questions or comments from the audience? Please feel free.
I have a question. The mobile phone has meant that as healthcare professionals we are totally always available. Will this system have such great expectations in time to come that there will always be an expert available to answer all the questions? Is that how you see it, and how do you manage that in the clinical situation?
That's a good point with the mobile phone. We are always at hand, and unfortunately some people don't realise that we have time off as well. So I'm constantly receiving phone calls from the rural sites or emails every day for consultations as well. Although I'm not meant to see new patients, I do via email. It's hard to, there are no boundaries. If they're there, and then, sometimes if they're in trouble, it's better that they do call us, and then we can deal with it quite quickly.
Yeah. I just see ourselves being more available, an expectation of patients.
It's there. That happens now to us. Yeah. It really does.
It's probably a downside of this system.
Sorry, it's about setting the boundaries and making it quite clear that the service, like we do now, we have a 9 to 5 through physical clinics. You say this is when I'm available and stuff. But what's nice about it, like Donna says, when they're in trouble, they can actually get help quite quickly. So I've done 2 consultations in the time I've been here for the conference. Now, if they had to wait till I got back to Australia, we don't know what the outcomes are. So, but you do need to put boundaries around it. You're not there at 3 a.m, for example.
Turn the phone off,
Benjamin,
Thank you.
Got a question?
Thank you for a nice presentation. It's really nice to see eHealth in its real area. In Denmark, we try to evaluate eHealth with patient only 20 kilometers from the hospitals. And it's a different view of telemedicine in your country. There's a really need of eHealth by saving transportation of 500 miles or so instead of Denmark. Are you using eHealth in other areas, ICD, COPD, or are there any evidence for that yet?
Our hospital is quite large. I do know that I can really only speak from the wound side of things, so I know that burns is very established, plastics are. I'm not sure if they're doing it in respiratory medicine or what's happening there. I know that the urologists do, or psychiatrists do, but I'm not sure really how their services run, to be honest with you. I'm only sort of familiar with my own.
I'm conscious we take up further time, but there's actually a gerontist who is based down in Melbourne, who runs an aged care centre in Queensland, and he has a little trolley that he goes on ward rounds, and the little trolley goes around, and the only limiting factor is his registrar has to push the trolley around. He's after a mobile trolley so he can do his own ward rounds. But this camera actually, this television screen comes up to the patient, they chat to each other, and he says, "Show me your leg." And so aged care are really starting to pick up now because it's another big diffuse area where you need the expertise. Yeah?